Okay, we'll go ahead and get started. Hi everyone, this is Lil Nedich. I'm the coordinator of the Harvard and Beth Israel Deaconess Medical Center site for the New England Mental Health Technology Transfer Center. Please feel free to introduce yourself in the chat box if you'd like. And now I just want to review a few housekeeping items before we begin. Next slide, please. Oh, do you have the, yep, okay, perfect. Participant microphones will be muted at entry. If you have questions during the event, please use the chat box. This session is being recorded and it will be emailed out to all participants once it becomes available on the website. If you have questions after this session, please email newengland@mhttcnetwork.org. At the end of this month, MHTTC will send you a certificate of completion. If you'd like, you can then use that certificate to submit to your particular board for continuing education credit. Please contact ifisher@c4innovates.com for more information on CEs after the event. Next slide, please. This slide is just our MHTTC acknowledgements. Next slide, please. The MHTTC network uses affirming, respectful, and recovery-oriented language in all activities. That language is strengths-based and hopeful, inclusive and accepting of diverse cultures, genders, perspectives, and experiences, healing-centered and trauma-responsive, inviting to individuals participating in their own journeys, person-first and free of labels, non-judgmental and avoiding assumptions, and lastly, consistent with our actions, policies, and products. And with that, I will hand it over to Dr. Keshavan for some introductions.
Okay, thank you, Lola, and good morning and good afternoon to everyone. It's my pleasure to introduce today's topic, which we have been looking forward to for a while now, on SMI Adviser resources for people who provide care for early course psychosis. The two speakers today are Dr. Robert Coates and the other co-presenter is Dr. Sherin Khan. Dr. Coates, whom I have known for a few years in a number of different settings, is a leader in the area of care for serious mental illness, and especially in the area of Clozapine treatment. And he is associate professor of psychiatry at Emory. He's also a physician expert to the SMI Advisors, which is Serious Mental Illness Advisor, which is funded by the SAMHSA and administered by the American Psychiatric Association. Dr. Coates is also the director of the Psychosis program at the Grady Health System in Emory, and runs three clinical programs, including a program for people with persistent and treatment-resistant psychosis, a program for early course psychosis, and a program for young adults with mental health conditions and substance abuse. Sherin Khan is Vice President of Operations and Strategies for Thresholds, which is the oldest and largest provider of mental health services in the state of Illinois. She's also social work consultant as part of SMI Adviser and has over a decade of experience in nonprofit sector. And so her expertise is in the area of cognitive behavioral therapy, DBT, ACT, and motivational interviewing. She brings a great deal of experience with her experience in the CCBHC, Community Behavioral Healthcare Clinic Standards, and she's a leader in the field, and it's great to have her join today's presentation. So without much further ado, let me bring you Sherin and Robert. Thank you.
Thank you so much, Dr. Keshavan. It's really great to be here. We really appreciate the invitation and have a great deal of respect for the work that's done at the MHTTC and in MapNet, and we are just really delighted to be here. We're going to be talking about SMI Adviser, in particularly resources that are available for people with early psychosis. Let's see. Here are our disclosures. And And here are our learning objectives. So by the time you leave this talk, we hope you can demonstrate knowledge of the available resources on SMI Adviser's educational catalog and knowledge base. List and describe 3 tools in SMI Adviser's Clozapine or LAI Center of Excellence. Outline the process of accessing SMI Adviser's consultation service, demonstrating the ability to effectively seek guidance to help make evidence-based treatment decisions. And throughout this talk, Sherin and I are going to be kind of passing the mic off to each other. And we have a couple of interactive exercises as well. So, you know, if you feel so compelled, you can unmute and you can provide some thoughts about a particular scenario that we're going to talk about and come back to several times during our presentation. Let's see. We also have a poll question before we get started. And I wonder if we can, Lola, maybe launch the poll. We're just curious to know who's with us today. So if you can just answer which role fits you best. And if we forgot a specific role here, we apologize and just choose other.
Kelsey, are the polls working for you?
Yep, yeah, it's coming up. It looks like we have about 2/3 of folks responding so far, so I'll give it another couple seconds, but yeah, great. All right, so I'll share it.
Great. And you know, I think in every poll I've ever made, other is often the largest category. So again, we apologize about that for not being able to accurately capture the role. And what's cool about this is it's like actually like a CSC team type representation here on this call, really sort of a wide range of different people and perspectives. And we are grateful that you all are with us. Okay, we'll stop sharing the poll. Okay, so we're going to talk about SMI Adviser. We are in year 6 of the grant. We are funded by SAMHSA, and we are administered by the American Psychiatric Association. We have a sweeping mission statement, which is to transform the care of people who have serious mental illness to live their best lives. Sometimes people say that, you know, the background and the marketing and everything looks kind of, you know, it looks good, and they wonder if there's a role of the pharmaceutical companies in all of this. And it turns out that there is not. This is actually a SAMHSA grant, and we we have an in-house marketing team, and we have people that help to make our slides look really great and our website. So this is all free resources that we have for people. They just have to sign up. And there's a number of different ways that people can engage with SMI Adviser, which we'll talk about during the talk. So SMI Adviser really focuses on 3 main conditions that encompass serious mental illness, including bipolar disorder, major depressive disorder, and schizophrenia. And I think one thing that stood out to us is that people, you know, like to learn in a lot of different ways. And we have different ways of interacting with SMI Adviser that are kind of based around people's different learning styles and how they like to contribute. You know, some people like to sit back and watch a webinar. Other people would like to watch sort of the discussion kind of forum. Other people would prefer to do a consultation. And during this talk, we're just going to do a little bit of an overview of the education stuff, our resources, and then how to make a consultation. We have a website and an app. And I'm not on social media, and I don't really know, I have no way of understanding how many clicks is a lot of clicks, but over 2 million people have visited the website. Seems like a lot. There's been about almost 40,000 downloads of the app. You know, you can basically search something like, you know, Clozapine levels, SMI Adviser in Google or any other search engine, and that's another way of accessing our content, which sometimes gets you there maybe even quicker than sort of fishing around on the website. So the app is available on Google Play, and it's available at the App Store, and it's yeah, it doesn't take up a lot of space, and there's some stuff on there that we'll talk about in a little bit. So the SMI Adviser team is divided into a central team and a clinical expert team. And the central team includes these very talented people we have here. Amy Cohen is the director of SMI Adviser, and we have a number of other team members who support the program. The clinical expert team is really a way of ensuring that SMI Adviser has multidisciplinary representation and really kind of focuses as an interdisciplinary team so we can get content to people that are that's relevant to a wide range of disciplines. So we have a family engagement expert. We have a pharmacist, John Toros, whom I'm sure you all know is also part of the SMI Adviser clinical team. And then we have a nurse practitioner who works with us, social determinants of health expert, a systems expert, and other clinicians who work with us as well. And really, I think having this multidisciplinary team I've learned a lot working with SMI Adviser over the last couple of years from this team and these different voices. Okay, so that's just a little bit about us. I'll hand it over to Sherin, who's going to tell us a little bit about some of the education catalog.
Hi, everybody. Again, Sherin Khan. I think he called me a doctor in the beginning, which I'm not. I'm a social worker, although my parents would love to hear that, being a child of immigrants. So I'm here just to first share with you a little bit about our clinician database. So we're going to start off there. We do divide it into clinicians, and then we do have resources for individuals and families as well. But we'll start with clinicians. And I do want to ask a question. Part of what we're hoping to do today is also take information back to see what resources are really helpful to people in the field. So before I get started and show you a little bit about our education catalog, I just wanted to ask two questions. The first one is, what do you find most challenging about your role? There's probably a list. You can give me a couple things if you need, but I just want to find out what is the most challenging part about your role. And you can, again, like Rob said, be brave, come off mute, or you can just go ahead and put it in the chat.
Hi, I'm Sarah. I'm she/her young adult peer mentor at Massachusetts Psychosis Triage Hub Empath, and do some stuff with Cedar at the Brookline Center. Thanks for the presentation. I'd say a lot of gratitude mainly, but a lot of also just balancing expectations of what the teens that I'm working with now need or ask for, and then what's expected of the team I'm working with and for, and any boundaries that come up for myself in between that. And I would speak for other CPS and peer mentors when I say that too.
Got it. Thank you, Sarah. Somebody else put the cost of the long-acting medications. Anyone else want to share anything that they find challenging? I apologize to those of you who thought you could just sit here. We're going to ask you a lot of questions and we'll wait. So, okay. So the second question I have is, what is your preferred, staff shortage, right? I've never done a talk where I've not heard that in the mental health field. Okay, so the second question I want to ask is kind of, what is your preferred way to consume or to learn or to do professional development? Is it through consultation? And that can be, you don't have to be our consultation service. It can be with your supervisor. Is it through webinar, more informational, or is it through, reading independently, or through even, live, they can be online, virtual, or in-person trainings? What's your preferred style to develop yourself professionally and learn?
I think interactive works very well for me. Yes.
Cool. I assumed there'd be a variety, but I just wanted to see. And that's something, that's unique, is that we do offer kind of all of that, right? So we have the knowledge base where you can just read if that's your preference. And we do offer more interactive trainings now, which I'll talk a little bit more about. Okay. Anyone want to vote for webinar? Just straight webinar? Okay. Okay.
We do have one vote, yes.
Yeah. I was just curious.
And we're all here, so doesn't that mean we're all voting for it anyway?
Maybe. It doesn't mean it's your preferred. This is just what was offered, right? Okay, so thanks for giving that information to me. Like I said, we want to make sure we have resources to meet the needs. Like that's part of our mission as well, is to have tools that are applicable to frontline clinicians. So anything that we put in our database, actually one of the criteria is it relevant to SMI? Is it evidence-based? And then the third is it relevant to frontline clinicians? So we really want to make sure that we're giving people things that they can apply in their work day to day. Okay, so you can go to the next slide, Rob. Okay, so this is going to be our case example that we use throughout. We were trying to think of a way that we could try to apply some of the tools that we show you today in a way that's not just us telling you about them or showing you. So we're going to refer back to Peter throughout the presentation. So Peter is an 18-year-old non-binary young adult who had their first episode of psychosis about a year ago. And they've enrolled in a CSC program at their community mental health center for just over that year. And they do receive individual group therapy. They are on antipsychotic medication, and they also are working on supported employment. At a recent appointment with their therapist, they reported having thoughts of suicide due to their voices being really loud and controlling. And this ended up with a breakup with their partner girlfriend. So Peter said at this point during the session that they would do anything to get the voices to stop. So the therapist, did an assessment and decided to send Peter to the emergency room to get evaluated. And Peter was committed to the inpatient setting. They were there for 3 days and are now getting ready to get discharged back to the parents' home. So during the first meeting after they get out, Peter meets again with a therapist and is really angry. Actually is meeting with the peer specialist, we'll say for this one. So they state that the therapist was blowing it out of proportion, the hospitalization wasn't necessary, and it was traumatic. And they don't feel like they can trust the therapist or the treatment team, and that really no one understands what Peter's going through. So Peter is open to considering a different type of medication, and they've only tried risperidone and are taking 3 milligrams nightly. So again, this is just kind of like a conglomeration of people that I've worked with, right? But hopefully not too far off from somebody that you might work with and kind of an experience of having to hospitalize. So the reason we're talking about Peter is because I want to apply the different areas that we go through to how you can apply it to a real client. So we can move on to the next slide. Okay, so this is our education catalog is what we're highlighting first. And this really is where we have our webinars, right? So this is mainly our purely educational webinars. And so we have, I don't even know how many, we have a ton of webinars and you can watch them in vivo, right? So you can sign up and watch them at the point that they're, marketed at, which there is benefit to that, right? Because then you get to have the interactive chat, because a lot of our webinars now have some pieces of interaction, and you can have a Q&A with the expert, or you can go in and watch at your own pace, right? And so, for those of you who have continuing education, this is amazing because most of them nowadays have continuing education credits for psychiatrists and other MDs, and for nurses and for social workers. And a lot of those can be applied to other disciplines, actually the social work CEs. So you can go to the next slide and we'll just show you a few examples. So just a variety, right? We have so they do give you over 270 live and on demand. And this is also where our virtual learning collaboratives are housed, which we will show you in a minute. So I think, let's see, if you go to the next slide, I can't remember if I have where I put the Peter thing. Okay. So if you were going to search for something what keywords would you use to look for Peter? If you were trying to further your education, what would you be looking for? What keywords would you search to find a webinar to help you better serve Peter? And I can do like a live, I'm gonna be on it. It's like a little quiz. So I'm gonna be on our app and tell you what we have available.
Negative symptoms?
Mm-hmm. All right. Let's see what we can find. I found some things in the knowledge base for sure around negative symptoms. Okay. And then I see a few other things. I saw suicide risk. We have quite a bit on suicide risk and kind of doing crisis management. We actually even run a 12-week collaborative that's focused on managing crises. We also have, let's see, engagement. We do a lot on engagement. Interestingly enough, when we do our consultations, the ones that I get the most of being as the social work, it's mostly on engagement. So we have a lot of resources, and I'll talk more too about, we actually created an SMI 101 for people who are new to working with people with serious mental health conditions. And a lot of that does focus on engagement. Yes, and hearing voices. Early psychosis, we have a whole LAI and Clozapine Center of Excellence. Yes, actually, we were one of the first to do, we did a series of 3 webinars on non-binary. And the reason we did that is because there wasn't enough out there. All right, we do have suicide assessment tools. Yes, okay. You know, actually the one I'm not finding something on is a traumatic experience of hospitalization. So that might be something for us to look into for sure.
Great idea.
And, you know, hopefully with 988, that's supposed to change, right? But I just know we're not there yet. Cool. So that's a good topic for us to look at, creating some knowledge on that's really related to the impact on the therapeutic alliance when the therapist uses involuntary commitment. So we'll take some notes. Okay, cool. Thank you for participating. Rob, I think you can go to the next. I kind of skipped ahead. Maybe I should pull it up so I know where we're at. But I don't know if there's anything. Okay, cool. So next are these virtual learning collaboratives. And these are, to me, this is my preferred learning style. I was going to say they're one of our best resources, but really there's, because the thing is, you know, when you go to a 1-hour training or you go to something, you know, for a couple hours even, you really only take away such a small percentage. I think they say it's at most 30% of what you've heard, right? And I think that's being generous. And so we have these virtual learning collaboratives, which are 12-week classes, which really get hands-on, in-depth, and interactive. So what I also really like about the virtual learning collaboratives are that they have multiple learning styles, right? So there's independent work where you read on your own. It could be an article, it could be, you know, something else, but usually, or you can watch a video independently. So we'll have things like that. And then you have either weekly or every other week, you have a live session with the expert, whoever's in charge of that VLC for that week. So we have found these to be really helpful. I've been doing a motivational interviewing VLC for 4 years now, and we still have over 500 people sign up every time. And what I like about that is that, you know, by the end of the 12 weeks, you can apply, of course, apply. So there's a lot of practical application as well. And you go out in the real world and you try something out and then you bring it back to the group. And it's a really good peer environment as well, because we don't always, you know, as the experts, we don't always know the answers. And so we rely on kind of that group and creating that collegial atmosphere. So we have several of these, and they're all 12 weeks, which we know is a huge commitment. But like we said, you can do some independently on your own. So I don't know if anyone's participated in one, and if you have and you'd like to share, you can do that. But we can go to the next slide and I'll talk about a few specific ones. So yeah, so I don't know, we have, actually, I would say most of them are pretty popular. We have our Mastering Clozapine one, which we have more on the next slide. And Rob, I might ask you to just share about that one since you lead it. And then we have our Introduction to Serious Mental Illness. And this was created because we realized there was that gap. And really, a lot of the consults and things that we were getting were around how to engage or really more basic information around serious mental illness, right? We know this is a specialty subset, right, of working with people who have mental health conditions. And so we want to make sure, part of our goal is to increase the knowledge, right, of the behavioral health workforce. So more people are interested and, willing to kind of help our subpopulation of people with psychosis or people with schizophrenia spectrum or major depression or bipolar disorder. And then a few other popular ones, like I mentioned, we do have a 12-week de-escalation training. So really, how do you kind of manage and repair relationships, right? So there might actually be something around that post-hospitalization repairing of relationship in that VLC. I'm just not super familiar. And then we also do have our motivational interviewing one, like I said, which is super popular. And just a little plug for me, motivational interviewing has been the most helpful approach to working with people with serious mental health conditions. I, of course, pull in, collaboration with providers and also other evidence-based practices that I'll talk a little bit more about later. But to me, motivational interviewing has been my approach of choice, where I've seen the most success for people with serious mental health conditions. And then the next slide, Rob, is the Clozapine one. If you want to just share a little, it's this one first. I'll go first. So these are kind of breaks down what's in our SMI 101. And really, what's really cool about this one is it is a multidisciplinary presenters. So Rob and I actually together created it, but then we have our systems expert who talks about the big picture and payment structure, which somebody actually already mentioned a little bit about. And then we have other experts like John Torres does our week on technology and mental health and really how can you use it to improve health outcomes for people. And then we have our expert in our de-escalation and risk who does, some of those weeks. And so it's really cool to get the different perspective and really think about how the total team approach really matters and works best for people with serious mental health conditions. So you can just take a quick look and kind of see what's in our 12 weeks there. And then Rob, you can go and talk briefly if you want about the Clozapine, because I think that's the next schedule.
Yeah, and just real quick about the SMI 101, we had thought that this would be really good for people who were like newly coming into working with folks with SMI. But we quickly learned that there were some people that were, that were pretty new to an organization, but there were also people that had a lot of experience that just kind of wanted to get a refresher. And I thought that it's been really interesting doing this virtual learning collaborative, seeing all of the wealth of knowledge that is actually like in the virtual learning collaborative. And it does feel really pretty collaborative. For the Clozapine virtual learning collaborative, I'll give you this scenario. So in the program that I'm part of, we recently hired a new psychiatrist, and she does half-time CSC and she does half-time Clozapine kind of work. And she's done a good bit of Clozapine, but she's going to be participating in the virtual learning collaborative, and she just got started, and the virtual learning collaborative is just getting started. So the timing of the 12 weeks, I think, is really going to work out well. The virtual learning collaborative on Clozapine itself really takes a pretty deep dive, and at the end, there's sort of a product that people can create where they can help to systematically monitor the side effects of Clozapine that they see. So in some ways, it's kind of like developing a measurement-based care approach towards working with people who take Clozapine. And then we kind of go down each of the different systems that Clozapine affects, and sometimes we bring in guest experts to talk about different considerations with Clozapine. But with this virtual learning collab, we actually have 6 office hours instead of 12 office hours. And it's kind of spaced out every other week. Okay. The next thing we're going to do is talk a little bit about our knowledge base. And Sherin had mentioned a couple of knowledge base examples that were pulled up in her search. And again, you can kind of access this both through the SMI Adviser website or by typing keywords into Google and then putting SMI Adviser at the end, and you can often get to those resources via this way too. So we have a lot of different what we call answer cards, which sometimes just have standalone content or can be linked to a different video or a different resource. And everything is actually peer reviewed. So everything usually has two peer reviewers that vet the content, make sure it's evidence-based. We have a process where we try to keep these updated as well. And one of the knowledge-based examples is on financing coordinated specialty care. And this is a document that David Sherin wrote for us that kind of talks about different strategies to actually finance coordinated specialty care. And I think is a really useful document. Okay. There's been a lot of learners that have taken part in our education, both webinars, answer cards, and other resources. And this is some of the feedback that they've gotten. And this person in the middle here has talked about how they didn't have a lot of experience with motivational interviewing, probably attended Sherin's VLC on motivational interviewing and found it to be a very valuable experience. I wanted to just talk a little bit about some of the resources available on the app. And I actually used the app in a clinical way, just sort of sitting down and talking with folks. I get on the app to complete various rating scales, and everything actually, and sometimes what I'll do is I'll take the rating scale on my phone and then transcribe it to the electronic medical record. And it's an easy way of doing something like the PHQ-9. We have a number of other rating scales on the app as well. And you don't enter any PHI sort of in the app, just so that's clear. It's more of a way to just sort of, kind of do a quick PHQ-9, particularly if that's something that your organization requires to do every once in a while. You can download it at smiadvisor.org/app. And we have another app, which Sherin's going to talk about here, called My Mental Health Crisis Plan.
Yeah, so this is a app for psychiatric advanced directives, specifically that can be made with the client or patient directly, and then they can have it themselves, right? Because we're not always going to be there in the case of a emergency, right? So I think it's across the board that you are have to have at least an option for somebody to create a psychiatric advance directive. And I know actually with CCBHCs, it is now something that you have to do at intake every time, and you have to, and then annually, and you have to offer, the help to do that. So this app is really, really helpful for that. And, like instead of when I've done them before, I've written them on like a piece of paper, right? And you're kind of wondering, where does that go? What happens? So this can be done and shared, especially, for young adults. Their parents can have it on their phone through a QR code. I do want to acknowledge that some of the issue we have with psychiatric advance directives are that not every hospital or law enforcement officer is going to uphold that, right? And so that's something that I think needs to be done at more of like a legislation level. But I found doing these with people very empowering, right? So we did talk a little bit about, with the Peter example, how traumatic hospitalization is, right? And we know that. And this does give some empowerment to somebody. So a few things to remember when doing a psychiatric advance directive are to do it when the person has, is no longer in crisis, right? So it's after they're out of, it could be done actually. I have done it when they've been in the hospital. I've done a psychiatric advance directive along with like a crisis recovery plan So you probably, I don't know, whatever people call it, right? It's always different. But really, I think I find very helpful to talk about what happened with the crisis, what could go differently next time, what can they be in control of, and that really helps to re-engage. So the PAD, you'd want to do this when they're in a clear state of mind, help them understand that their preferences will be followed as best as possible. But it's possible it's not always, going to be possible. And then you want to include their parents depending on their relationship and their age group, just so that there is somebody who's usually going to be with them, a decision maker who can act on their behalf. So this app, so people have been using it really, and what it does is it helps people really state what their preferences are. I would get a lot of people who would say, I want to go to this hospital. That was something that we couldn't necessarily control, because for us, at least in the Chicago area, they take you to the closest hospital, even if they don't have a psychiatric unit. So that's always fun. And then it designates somebody to make decisions if they're unable to. They can access it anytime through the app, and they can share it with people, right? So people who are part of their support team. And also you would have access to it as well. So we can go to the next slide. And I think we're going to talk about Peter again. So remember our friend Peter. So I think I just want to ask a couple of questions. So number one, would you complete a psychiatric advance directive with Peter? Do you think this is somebody that would be a benefit to? Cool. Hopefully I got a yes. We'll go with that before somebody says no. And then, how would you bring it up, right? I found that clinicians struggle wanting to, especially if you were the person that, that had to hospitalize them the last time, it can be really hard to kind of bring this up again, because then it's already talking about the possibility they might have to return. Yeah, exactly. Right. So you would first engage in that conversation around what it is, why it could be helpful, but then it is their decision. And what type of questions do you think you would ask or include in a psychiatric advanced directive? Yeah, you could definitely, Monica, bring it up in that conversation. So there's a few ways to kind of approach after hospitalization. We have something, it's called a life space interview. It's an interesting word. I don't know if any of you are trained in therapeutic crisis intervention, but one of the things we do after hospitalization is the life space interview. So the life space interview, or modification you can make to it, what that does is really looks at the hospitalization and what were the behaviors that led up to it, and then what would they have liked to have gone differently? What could we do differently to try to not only prevent the hospitalization, but really just kind of manage some of the behaviors or feelings that led up to the hospitalization. And a big goal of the life space interview is also to really re-engage, right? So re-engage between the provider and the person, because we do know that, hospitalizing involuntary can lead to those ruptures in relationship and in the engagement process. So that's one piece that we would do, would be the life space interview. And then the second thing that we do post-hospitalization is like the crisis recovery plan, which does feed into the psychiatric advance directive. So the crisis recovery plan, or whatever it might be called, really looks at what do we do when you're headed towards a crisis, right? So, this just happened. We talked about the last event, right? But what do we do the next time, right? So what were some internal warning signs that you had, right? What were some signs that other people could recognize, right? So what might I see as the clinician? What might your parents see? What might your friends see? What are those early warning signs? And then what are some interventions or coping strategies or whatever it might be that could help you when you're headed towards a crisis. And so, we want to make sure we really get those specific and unique to the person. And then the other thing that's included in these crisis recovery plans are also who can you reach out to for support, right? So who's somebody that and is it a warm line, or is it a friend, or is it your provider, right? So it really just depends. So that's kind of a second component. And that feeds into the psychiatric advanced directives. And these have more so on if you're actually going to need to be kind of hospitalized, if you reach that level. So it's like, how do you want to receive your care, right? So where would you want to go if you have that choice? What type of treatment is your preferred, right? What medications are you okay with? What medications are you not okay with? So really going into, and then who should be notified, right? So who needs to be notified right away? We used to chase people as they were being taken to the hospital and try to give them or actually like our information so that they'd be able to give that to like the nurse or the social worker at the hospital. So really, which individuals do they want to be to support them? So it really talks a little bit more about kind of the actual logistics, but they're all related and they all kind of need to go together. Actually, yeah, you're totally right, Monica. We don't just use it after a crisis. We do it again after a crisis. So we use it as part of our annual, or we have to do it twice a year, our twice a year assessment, or whenever somebody could possibly be headed towards a crisis. But when somebody's already kind of in that state, we find that it's a little more challenging, right, to do a crisis recovery plan. So we found doing it after a crisis is really successful as well. Even if they did one, say 3 months ago, it was part of their annual, assessment that we have to do. At that point, we're doing so many different assessments and they're not thinking about a crisis because they're not in that state. So when you do it right after a crisis, somebody has that like a lot in their memory, right? It just happened. So I found that those crisis recovery plans have been the most successful. But you're absolutely right. It's not just to be used after crisis. We've just found that that's when we can really get them to be super applicable, right? So that way, instead of just somebody saying like, oh, I can go for a walk when I'm feeling upset, they're like, no, when I just felt upset, 2 weeks ago, here's what would have helped. So good point. So that's just an example to show you how you can use psychiatric advanced directive and a little bit more information, just because it came up already, around how to do, what to do after a hospitalization or before, to try to make it as not traumatic as possible and to try to preserve the relationship. Yep. Yes, I'm just reading the next chat. Yeah, so we do actually, Sarah, we will apply, that is in there for a reason, just so you know. We'll talk about how to apply that exact phrase. No one understands what I'm going through in a later section. Because yes, normalization, especially in early psychosis, is super important. Okay, so I'm going to shift gears a little bit and talk about some of our online skills refresher courses. So actually, I developed these and it was based on my own experience working with people who have really serious mental health conditions. I found, everyone says the evidence-based practice is CBT for psychosis, right? But what I found in my work with people who have pretty severe symptoms or severe mental health conditions, that it wasn't always easy, or I wasn't able to sit down for 12 to 16 weeks, right, and go through a CBT, for example. So what I learned over my time working with people is that really like having kind of a whole toolbox of these different evidence-based practices that I could apply to the person based on where they're at, based on who they are, based on what works for them, was the most successful. So I think about a year ago, created this online skills refresher series that goes through kind of the big 3 main evidence-based practices. As I mentioned, I do everything from my motivational interviewing lens. Particularly important to me there is the spirit of motivational interviewing. And that's really, it's actually very much what was included on that initial slide about MHTTC and how we use, how we think people strengths-based, non-judgmentally, empathetically, and really, that unconditional positive regard, and then stages of change. But you need other interventions from, other evidence-based practices. So for CBT, what we do is we really go over an overview of what cognitive behavioral therapy is, with special attention to psychosis, and then, to delusions actually in particular. And then it's like a workshop actually. So we do a lot of interactivity, because my goal is that people can walk away knowing how to apply 1 or 2 skills from CBT directly to their work. So we focus a lot on cognitive restructuring in the CBT one, because that's what people have found to be helpful in working with people who have psychosis and in delusions in particular. Then the second class that we offer, and you don't have to attend all three, you can attend one, is the dialectical behavioral therapy. So we also, again, go through what DBT is, what is, the core to it, right? And mindfulness. And then we focus a lot in DBT around how to use those distress tolerance skills. So there's crisis distress tolerance skills, and then there's other distress tolerance skills. And then we do focus also in the DBT one on your interpersonal skill building. So again, there is practice throughout because I want people to walk away being, oh, I can do this with a client tomorrow. And then the last one, which is another one of my favorites, is acceptance and commitment therapy. I have found this invaluable working with people who have serious mental health conditions. And the reason is because really the values. So the core of acceptance and commitment is that you accept what it is that you are dealing with, right? And we accept that pain is a part of the human existence, but suffering is optional. And the more that we attend to whatever it is, the more energy that we give to our mental health condition or our stressors, then that can actually lead to, it can increase it and also lead to other mental health conditions. Not to diminish them by any means, right? We know how hard it is, but really what it does is helps you to accept and to try to diffuse those so that you can then commit to living a life of your values, right? So I love values because I have found working with people with serious mental health condition, when you talk about goals, a lot of times they're just going to tell you like what they think they should say, like their treatment goals. Oh, I want to get a job, right? And really values help you identify what's important to them. So even if somebody isn't hitting those traditional milestones, they're still living a life of purpose. So those are the 3 skills refresher series. They're just 2-hour workshops, and we're offering them again in June. So just a little bit of information. And again, like I said, so you can add to your tool belt and you can walk away knowing how to specifically apply things from different evidence-based practices. Okay, I think it's still me, right? Consults. All right, so this is another service, which I actually will have Rob talk about as well, because we get totally different consultations. So this is something that I don't believe is offered anywhere else that I know of, right? When people think of consultation, they think of client-centered consultation that you might do with your team. There's probably a specific model that you follow with your team, or they think of consultation through supervisors, which are still super, super important. But we do offer this consultation service through SMI Adviser. And you can go to the next slide. So what you do is you submit it on our website. Oh no, these are the 3 types. There's 3 different types. You can go ahead and email or submit through our site. You can have a live discussion with an expert, which we'll do. We definitely, have mini consultations. And then we do implementation site projects, which are more like involved consultations. And we've done that, for example, when we were like rolling out our digital health navigator curriculum, or Rob will talk about one in a minute with the FBI. So those are the more invested, but we have also consultations just for individual clinicians. So you can go to the next slide. So yeah, this is our online service that you'll receive guidance within 1 business day. And you submit it through our website or through the app, and you can ask about specific cases, right? So we want to be mindful of HIPAA information, but you can ask about psychopharmacology, which are the ones that Rob gets the most of, I would assume, therapies, that's the ones that I usually get, and then recovery or patient and family engagement or education, and more. And so, we do understand that we can't give you exact information because we would need usually more information around the patient. But we do give you resources and tools and hopefully give you questions that help you to start thinking about whatever your case is differently. So that's our goal there. The ones that I get the most of, like I said, are actually usually around engagement, even if the question isn't around engagement, right? So I might get, this person isn't, they're not making any progress. What do you think I should do? Or I just got one, somebody's in a substance use recovery program and they're still using, and what do they do, right? So there's a lot of, that's a lot of the consultations that I get, and it's just helpful to have another, you know, set of eyes. And again, depending on the question, it will be answered by whoever is an expert in that, right? So it could be me or Rob or anyone else from our team, depending on what the question is. Or you could even just write in and say, I need some resources, right? We understand how busy clinicians are with all your responsibilities with your clients, as well as with your paperwork, right? Or billing. And so we know that, you know, sometimes it's just helpful to have somebody else provide those resources for you. So we can go to our next slide. Yeah, so we've had over 5,700, so that's a lot, and just some kind of, you know, reviews on our consultations there. You can see that psychiatrists use it, social workers, counselors, peer support specialists, administrators. So yeah, it's pretty unique. It's unique to us, and it can be helpful. We can go to the next one.
Yeah, and some of the kind of consults I've gotten, you know, particularly around early psychosis, are around things like, you know, what is the risk of relapse if somebody discontinues their medication after a first episode of psychosis? Or, you know, what if somebody has brief psychotic disorder? What is the risk of progression or of change to schizophreniform disorder or schizophrenia? Actually, there's a lot of questions that we sometimes get on the potential impact of various substances on sometimes symptoms, and how to help kind of work through that and differentiate that. I get questions on movement disorders, sometimes complicated movement disorders, and sometimes it helps when the consultation person submits those. We might actually look at like a de-identified video with that person together to look at the movements to see if there's anything else that we can tell. Sometimes it's very difficult to describe those over the consult system. And I guess I'd also say that, you know, writing the consult question is a sort of a skill itself. And Sherin is going to talk a little bit about this in the next slide, but I've been encouraging my residents and medical students to really think about, like, how do you ask a question to get, you know, a helpful answer and the answers you need to kind of inform care.
Yeah, that is a skill, and something that we practice. I don't know if anyone's doing any prompt engineering right now with ChatGPT, but also something we practice with our case consultations, right? So a step of the case consultation is really figuring out what the question is. And I do find a lot of my time is spent in my consultations trying to figure out what the actual question is, right? Yeah, cool. Okay, so again, back to Peter. So if you need a little refresher, but Peter, what would you write a consultation for? What would be the topic? So just, you can give me a couple topics about, if you were going to seek a consultation, what would the topic be? I'm going to sit in silence for another 20 seconds before I give the answers. Yeah, in one of the consultations that you could submit as we just explained them. One thing we've already talked about, right, quite a bit. One would be possibly repairing the relationship, right, after a hospitalization, and what do you recommend there? One could also be around preventing hospitalization moving forward, right? Anyone else have any thoughts, or I'll keep listing some off. Other possibilities could be on how to engage in other, you know, right, Peter's feeling alone. So how can we engage them in other communities and peer support networks, and any kind of normalization efforts that we might want to do to make them feel not so alone? I think another one, right, around the medication for sure. So it looks like Peter, and we'll talk about that in a little bit specifically around how you could use it. But yeah, they're open to maybe a long-acting injectable. Probably not, Monica. I can't say, right? I think that it could help make that process smoother, possibly, but it could have, I mean, I think that in part of your work with the individual and through your supervision, you should always be thinking about how to prevent unnecessary hospitalizations, right? You know, and I think some could be to be expected, but I think that's part of our goal as clinicians is to prevent those unnecessary hospitalizations. Obviously, sometimes they are really needed because safety is our top priority. But it could give you some more information. Yeah. So I think if the person, it seems like this is kind of a sudden thing for Peter. So I don't know if we knew that he was leading towards that. But I do think that moving forward, right, that should be kind of a goal of ours would be to prevent those. And especially it seems like that's what Peter wants. Yes, I think it really depends on how you would ask the question, right? So I think asking, you know, how can we re-engage somebody after a traumatic hospitalization where the therapist was the one, you know, who had to do it? How can I educate somebody around my role as a therapist in the hospitalization process, right? Without, you know, then worrying that the person's not going to share with you. Maybe how can I do a suicide risk assessment, right? What's information around how to do that? As we don't, you know, maybe you don't have one standardized at your agency. You can ask, you know, how do I approach somebody who's interested in taking long-acting injectables? What are some facts that they need to know, and how can I share that? Any other thoughts, Rob, from your standpoint, maybe on some questions that you could ask in a consultation to help with this?
Yeah, you know, regarding the last point, I think how to discuss long-acting injectable medication is one that comes up sometimes for us, and using different aspects of motivational interviewing, for example. And there's actually a couple models that are pretty useful. You know, for example, like the GAIN approach to talking about long-acting injectable medication could be another way to phrase that consultation question.
Great. So just to give you an idea, and to be clear, these consultations shouldn't replace your supervision, right? Or your team consultations. These are just to supplement and to provide you with more resources and, like I said, a different way to think about it. Okay.
So I think maybe we can talk a little bit about some of the implementation sites or kind of organizational consults that we get. So they really have varied widely. It's a free service, and we can do pretty in-depth consultations with people. Some of the kinds of organizational consults we get are like, how do I implement measurement-based care in my setting? You know, like how do I, one of the consults was around, how do I incorporate the BPRS into our clinical workflow? Or, you know, like how to incorporate the DLA-20 or things like that, that require some buy-in from people who are there, and then require some thought about how do you actually make that meaningful to people who are, you know, providing services. And you know, another type of consult implementation that we get is, how do I start a Clozapine clinic, for example? That's one that we've done a number of times, and we kind of have a framework for how to begin setting that up. We also had another interesting implementation site where, you know, the sort of federal SAMHSA funded thing was working with another federal organization, the FBI. And in this consult, just to tell you a little bit about it, we worked with the National Threat Operations Center, the NTOC, which is in Clarksburg, West Virginia, which is where I'm from originally, from West Virginia. And they consulted us around helping their threat intake examiners get a little bit more awareness around mental health conditions, and we developed a curriculum for them. And yeah, it was really interesting, and I hope that it was valuable. But we, you know, incorporated a lot of principles of recovery and shared decision making, motivational interviewing, kind of how to talk with people in a respectful and kind of humanistic way. So that's just sort of one example of the consults. I'm going to talk a little bit about some of our specialized resources, and some of these are, these are going to be around medication. And I know that there's a couple prescribers here, and many other non-prescribers here. And I think that it's really important that to know that I work on a coordinated specialty care team every day, and the decisions that or I guess the conversations that we have about medication with an individual are often framed by kind of what the team around is, those sort of conversations that people are having with medication, or about side effects, or about medication consistency and those sort of things. So the team plays a really, really important role in how we talk about medications, and then how medications come into the conversation with that individual. So we're going to talk a little bit about the Clozapine Center of Excellence and the Long-Acting Injectable Center of Excellence. First, a little bit about the Clozapine Center of Excellence. So everybody knows that Clozapine is highly underutilized in the United States in comparison to other countries. Of people that are living with schizophrenia, about 4% are currently prescribed Clozapine, and then it turns out that maybe 20 to 30% or so could benefit from Clozapine. So it's highly underutilized because of its side effect profile, and clinicians often feel uncomfortable prescribing it. So we have this Clozapine Center of Excellence to provide resources for people. There are about 20 prescribers who are actually on a Clozapine Center of Excellence call, which helps to guide our agenda and our resources. And I think that that in early psychosis work, this is really the time to start thinking about Clozapine. If you look at the predictors of good Clozapine response, it's about fewer antipsychotic trials, fewer psychiatric hospitalizations, and then minimizing the duration to treatment resistance or Clozapine exposure is actually very important. And this study actually looked at the delay to Clozapine initiation and the response rate of Clozapine. And you can just see, looking at 2.8 years, less than 2.8 years versus greater than 2.8 years, a pretty significant difference in the response rates to Clozapine. So in the CSC team that I work on, if somebody is, for example, prescribed a long-acting injectable medication and they're having some persistent symptoms, we can begin talking about Clozapine very early on, and the entire team knows about Clozapine and kind of can talk about Clozapine a little bit. CSC teams really play a key role in sort of addressing Clozapine underutilization. And another benefit is that CSC teams can help to determine how many antipsychotic medications has someone actually been on. Instead of waiting until it's 7 or 8 antipsychotics, we have an opportunity to have Clozapine be quite effective after 2 antipsychotic failures. So one thing that we really focus on in our CSC team is, how do we reduce the duration to treatment resistance, not just the duration of untreated psychosis. A couple of resources I wanted to share with you all a little bit. One was around the Clozapine dose planner, and the Clozapine dose planner is something that I talk with my clients, my individuals and clients I work with. So we'll have like a computer screen, and we'll talk about a couple different things that that this dose planner can help us with. For example, if you want to try to predict the Clozapine
Rob froze, and I can tell you I can't take over about medication, so I'll give him a second to try to come back. And if not, let's see if I can take over share screen, because I can talk about the individual and family part while he's getting his. All right. Yeah, I think you can hear me though, right? It's just Rob. Okay, cool.
Yep, you're coming through.
Okay, awesome. Okay, I'll go ahead and take over till he can get back in. Let me pull it up. And the last part we're going to talk about, so we'll just do it out of order, is this resources for individuals and families. So I've been seeing, you know, quite a bit of chat about the need for peer support, right? And so I definitely agree with that. And we know that's super important, not only for first episode, right? But throughout, because really that's what I've seen when people, especially when people don't have any hope, right? Really the only way that people can find that hope is through the peer support part. And that can be, right, it doesn't have to be a friend that you meet up with all the time or an in-person group, right? There's so many different, it could be your specialist, or it could be even like an online forum, right? But what we know is, you know, early episode psychosis is really, really scary, right? And it really, really makes people feel alone. And so what's super important for us is to make sure that we're providing education to help normalize that experience. And I mean normalize it in a clinical way, which is to help them feel like, you know, see how other people also deal with this. You know, I'm happy that we're moving towards the direction where mental health is, you know, more talked about and going to therapy and treatment is more accepted, but it still is really, really stigmatizing for people. And so one of the ways we can work to combat that is through, you know, providing more education for individuals and their families. So we do have a tab just for that. We work closely with NAMI, if you're familiar, and yeah, exactly. Good point, Sarah. So we work closely with NAMI and other organizations to make sure, and, you know, like you saw, we have a few actual individual and family experts on our clinical expert team. And so, you know, some of the different resources that we have in here, just to kind of help individuals and families get more guidance, right? So as you can see, we actually have a section on first episode psychosis, which includes fact sheets and other things, what to know about a new diagnosis, right? So again, we really focus on the main three. That's just our area of expertise. What medications mean. If you start taking medications, do you have to be on medications for your life? Also, you know, the term I try to say serious mental health conditions, even though we're branded as SMI. I guess it can go both ways, right? Because calling it an illness also shows that it's like the same as a physical illness, which is what we're trying to do. Oh, Rob is back. Rob, I just switched orders, so I'm just doing the individual and family, and then we'll go back to you. And then, yeah, so what is serious mental illness? What does it mean? And a lot of fact sheets and information here through our individual and family portal or pages. We also have these like really, these whiteboard videos too. You know, again, we know that clinicians learn differently and that applies to anybody, right? So there's a series of these whiteboard videos that really help people understand, you know, what mental health conditions are, where they come from, more information around how the brain works, what medications there are, what do you need to know about a diagnosis? And then also even like, how can you seek out supports? So there's links and other resources about how can you, as somebody newly diagnosed or somebody just wanting to learn more about your mental health condition, what other resources and supports do you have? And then we do have video series too of people who are living with serious mental health conditions. So I found, you know, normalization through videos to be really helpful, especially for young adults. You could do it through YouTube, but you can also do it here. So we have people who have been on Clozapine, for example, trying to dispel some of the stigma around Clozapine itself. And then just other people living with SMI and their experiences with recovery. How can you, what should you be sharing with your support system, and how can you work together and partner with your clinician or care team to get the most out of your recovery? And then infographics, right? A lot on facts. Like I mentioned, there's a whole fact infographics around myth versus facts on first episode psychosis. And this one is about words and how they're so important, right? So a lot of those infographics that people can look at quickly for fact sheets and myths versus facts. And then variety, we have, like I said, on first episode, but on different disorders as well. And then suicide prevention and crisis preparation. So I wonder, I haven't looked at that one in a while. I wonder if that would actually help guide a lot of what we were talking about earlier with Peter. So we're going to return to Peter just really quickly. And you can share, I can see a peer advocate in the chat, which I love. So what from individual family section would be helpful to share with Peter or his family, or anything else that in terms of, addressing the individual and family, anything that you think would be helpful to share? It seems like we have some already in the chat, right? So some first episode programs do require family involvement, right? And then this can give you some resources to help empower them, right? And then we have our peer mentors and recovery coaches. So yeah, there's a lot of options, but anything specifically that you think would be helpful to share with Peter or with Peter's family? And the goal here, right? I mentioned a few, but that's the reason I put that phrase in, that that they feel like no one knows what they're going through, right? Because I wanted to make it clear to express that need for somebody to understand, right? And the best way to do that is from somebody explaining, their own journey of recovery. Yeah, exactly, right? Helping parents learn how we can involve the family more. Exactly. Yep. And building other social supports.
I think also, this is Sarah, generally providing supports for parents is good too, especially as Peter is older and also is like non-binary. Like there's often there can be like worst case scenario, a lot of like misunderstanding and disregarding of like where Peter's at, just generally apart from the psychosis experience. And I think there's a lot of control that I see with like, or expectations also, like, well, I wanted my child to do this, and I wanted these goals for my child, and that's not happening now. And so what types of supports do the parents also need, obviously, to like support Peter, and also to like give Peter the space to grow, which might happen apart from the parents?
Yeah, those are great points, right? This is a very important period in their relationship, and to make sure that the parents feel supported and educated and know how to talk about these things that Peter is going through is so important. Yeah, so we should have some on family peer support, and that could be actually in either section. It might be in the clinician, or it might be, because we have a lot of peer support specialist specific materials in the clinician side, but then also I think you can search generally through the site. So yeah, great points, and thanks for sharing. And like I said, we just picked Peter so we could kind of show you how all of our resources can apply to one specific individual. Okay, so Rob, I'll stop, I'll stop sharing if you want to try to pick it back up, so that way go back to where you were, because I think that's what we had on that.
Great. Actually, Sherin, can you share again and we can just go back?
Yeah.
I think they're trimming a tree around my house, and they cut my internet cord. So
well, you got back on fast, because I was like, I can talk about almost anything, but not Clozapine probably so much. All right, so let me share again, and you can tell me which slide you were on.
I'd like to go back to the example of Peter and talk a little bit about the yes.
Okay, great.
Perfect. So, we talked a little bit earlier about the potential question, as a potential consult question around how do you kind of talk about a long-acting injectable antipsychotic medicine for somebody, and it's a great consult question. But then also there's this other part about decision making, like what do you do? What do you think about? And like when I read this vignette, there's a couple things that I'm thinking about. One is Peter was experiencing some suicidal thoughts, And that makes me think about clozapine, actually. That's one of the 2 FDA indications for clozapine. And a lot of times, clozapine is, we know, widely underutilized in the US, but even more frequently underutilized for its other FDA indication, which is the reduction of suicidal thoughts, reduction of suicidal behavior for people with schizophrenia or schizoaffective disorder. So that was one thing that came to mind for me. But then also, you know, Peter's open to considering a long-acting injectable, and no, we don't really know, you know, if Peter was taking the medicine before, but you know, Peter's right now taking 3 milligrams nightly of risperidone. So we have this tool that can help, you know, prescribers kind of think about like what options are available, because there's actually a lot of options available now. So if we go to the next slide. This is called the LAI Explorer. And, you know, part of this was done because we are sort of recognizing all the different long-acting injectable antipsychotics that are there now. And as we heard from, you know, one of the audience members, these are expensive, and they have a lot of different properties, and sometimes it's easy to kind of get things mixed up with them. So this is sort of the LAI Explorer landing page, and we have a couple of different things that you can check, like what are the indications, the generic drug name, the maintenance injection site, like intramuscular or subcutaneous, the maintenance injection interval, how it's stored, if there's an oral overlap or bridge period that's needed or not, and some other ones too. So let's go to the next slide. So, you know, like, let's say we talk to Peter, and Peter would prefer a couple things regarding their medication. Number one, Peter would prefer to stay with something similar to their current medication. And then, you know, Peter said, ideally, if they could take a medication that lasts 2 months, that would be great. So let's just sort of fill this in the LAI Explorer and hit the next. So these are some things that somebody could check on this tool. You know, they're thinking about paliperidone or risperidone. Then you can go down to the maintenance interval section, and you can click on every 8 weeks, every 3 months, or every 6 months. Okay, next. And then this is kind of what the LAI Explorer gives you back. It gives you 3 different options: Invega Hafera, Invega Trinza, and then Uzedy, based on what Peter's preferences were. Let's say you then click on Uzedy. It then pulls up some information from SMI Adviser on what you need to know about Uzedy, and then it gives you a dose conversion tool of oral risperidone to Uzedy. Okay, great. Now, if you don't want to go through the LAI Explorer tool, there's also an LAI conversion tool, which allows you to input the medication like aripiprazole and then what the dose is, and then it will give you different long-acting injectable medication dose options. And this is really one of the more frequent consult questions we get. It's like, how do I take somebody from an oral medication to a long-acting injectable medication, and what dose should we use? Also, people ask a lot about, how do I cross-titrate someone from one long-acting injectable to another long-acting injectable? And we have some resources to think about those considerations too. Okay, next. You know, one of the reasons that long-acting injectables are sometimes underutilized is because sometimes there's not a lot of infrastructure in place or to actually provide the long-acting injectable medication. And we've developed, got to credit Donna Rowland for developing these great, and others for developing these great videos on how you actually administer long-acting injectable medications. They're on YouTube. And there are 5 different sites that are discussed: the deltoid, ventral gluteal, dorsal gluteal, upper outer arm, and abdominal injections. And these are really, really helpful. And if anybody's going to the APA annual meeting coming up in May, we actually have a session on how to administer long-acting injectable medication. So we'll have a number of different injection sites. For example, I'll be at the deltoid station. You can find me at the deltoid station. And we'll have some of the actual unique formulations of the medication that kind of go over, you know, how do you actually give them, and what do you do with the preparation? Okay, next. And we also have a listserv. You know, our listserv talks about clozapine and LAIs, but also other things regarding medications, including lithium, are sometimes discussed on the Clozapine and LAI Centers for Excellence Exchange. It's a moderated forum as well, so only evidence-based posts really get through. We really try to keep it, you know, in sort of in keeping with the current evidence. Okay, next. Oh, and we have a virtual forum, just kind of getting at other ways for people to learn. So we have a cohort that we meet once a month on, I think it's on Wednesdays at 4 Eastern, and we alternate clozapine and long-acting injectable topics. It's a 45-minute long topic. The first 30 minutes are pretty interactive. We have a number of discussion questions, and then the final 10-15 minutes are actually a didactic style presentation. Next.
My computer's there we go.
Great. And these just go over some of the topics that we talk about at the Clozapine and LAI forum, virtual forum. We did one recently. I know Rob Laitman was a presenter recently, and we did one recently on clozapine and fluvoxamine and kind of what do we know about this combination. So we try to kind of capture some hot topics, interesting areas, some where there's, you know, we hope even some debate about kind of what to do. The other thing that we're hoping to do in the next Clozapine virtual forum, which would be interested of this group, is hopefully a Clozapine and early psychosis special virtual forum. Next. Oh, and also SMI Adviser is a great way to get out key information about just sort of new things and things that are trending. And one thing that everybody's that you know we've been following very closely is if they'll make any change to the clozapine REMS. And there was a release of information from the FDA in September that talked about the 3 new studies being developed to understand if a modification can be made to the REM system. Okay, next. And next. And next.
I already did
Okay.
this part. Yeah, I think we
Great.
can stop share and just see if there's any questions in our remaining few minutes. Somebody asked me for one of the resources, so I'm going to pull that up. And Sarah has a question. What's modifying the REM system?
Yeah, sorry. Sorry, Sarah, I didn't clarify that very much, but the REM system is it's in place by the Food and Drug Administration for certain medications. It stands for Risk Evaluation and Mitigation System. And it basically means that in order for, and there's different sort of levels of regulation, and clozapine happens to have a REM system in which every time somebody dispenses a prescription for clozapine, the blood work actually has to be uploaded into the REM system to verify that the person can get clozapine. So there's a system in place, and it turns out that the system probably makes it more difficult for people to get clozapine.
Do we have other questions related to SMI Adviser or anything that we talked about today? I know it was a lot of information, so I appreciate you for bearing with us, and hopefully you know now how to use the tool. Well, all the tools moving forward.
Yeah, I have a question. So great presentation by both of you. It's very, very valuable. One question, there are 2 questions. One is a more broad level question. You know, when we say SMI, what is SMI? What is not serious? How does one draw the boundary between serious mental illness and not so serious mental illness? So that's one. The second is, do you have any resources or any recorded sessions on managing clozapine resistant population.
Yeah, so I can start with the first one and Rob can add. You know, I think it's like with any diagnoses, right? It's important because it helps to classify and drive treatment and interventions, right? And it also helps people to understand how serious the impact is of the condition, right? So when we think about serious versus other mental health diagnoses, it's really about the impact on that person's functioning, right? And their ability to kind of maintain their relationships or some career of their choice, right? So I like to think about an impact of functioning rather than even really having to categorize it into serious or non-serious, because it's all relative to the person. I can have a diagnosis of schizophrenia and so can Rob, but it's going to look different. And it could be that for me, it you know, shows up in one way and I'm still able to, you know, maintain a healthy relationship and employment or something, whereas Rob's impacts him much greater and he doesn't. So I think, you know, the category of serious mental illness was decided prior, right? Like it's been decided for a while. I know it's like what Medicaid takes for us at Thresholds, for example. We only work with people who have serious mental illness and it's categorized by Medicaid. So I think it's, you know, important to understand the distinction and also just think about the person individually and what treatment they need.
Yeah, Sherin, I would agree. And also I think that there is a degree of arbitrariness to it as well, you know, and I think that it's one of those things that can kind of change on a continuum. And as far as the scope of SMI Adviser, you know, we've really been asked by SAMHSA to focus on three main conditions: schizophrenia spectrum disorders, bipolar disorder, and major depressive disorder, severe. And you know, regarding your second question, Dr. Keshavan, on clozapine resistance, we do have a number of resources about this. This is a major area because so many people, it takes so long to get onto clozapine sometimes. And then when you get there, when some people get there, sometimes they don't have the response that they're necessarily looking for. So the pharmacologic and psychosocial interventions for partial clozapine responders is I think a major challenge. And on SMI Adviser, we have some answer cards and some webinars to help look at this. You know, and it's kind of actually in different places. So, you know, we did a virtual forum the other day that's recorded that's sort of on non-antipsychotic pharmacologic augmentation strategies for clozapine partial responders. And this sort of goes over the literature that kind of talks about all the different, you know, mood stabilizers and other medications that are not related to antipsychotics or ECT that people have tried, and kind of going over the literature for positive and negative symptoms to, you know, to potentially be helpful with that. I just recorded another talk on managing persistent positive symptoms for clozapine partial responders. That's a 50-minute talk. And then Jonathan Meyer has about a 15-minute talk on this as well. His 15-minute talk might even be better than mine. I don't know. It's very good. But there are some resources. It's a major focus. And you know, I think we just have a lot of work to do as a field to really help some of these folks.
Thank you.
All right. Any other questions? Or I think there's just a reminder to fill out your post-event survey in the chat. Okay, well, thank you for your time today, and hope everyone has a great day.
Thank you.
Thanks so much.
Thanks, everyone.